Good morning. My name is Dr. Stormy Monks, and I'd like to welcome you today to our Grand Rounds presentation hosted by the Southwest Center for Pediatric Environmental Health. The Southwest Center for Pediatric Environmental Health is one of 10 PACEUs in the United States. And the purpose of the PACEU program is to serve as a leading national source of medical information and consultative advice on environmental conditions that affect development. To serve as part of our mission, we offer this Grand Rounds series once a month, normally on the third Thursday of each month. And today we're so grateful to have Dr. Jordan Vaughn with us. She's going to be speaking on violence prevention and injury as a public health crisis and a focus on our pediatric population. Before we move forward, I would just like to take care of a few housekeeping items. You will not be able to share your screen and you will not be able to unmute. So we ask that if you have any questions to please put them in the chat or comments, and at the end of the session we will read those out to Dr. Vaughn so she can respond. We would like to thank our partners at the U.S. Environmental Protection Agency, the Agency for Toxic Substances and Disease Registry, and the Public Health Institute. Without the work of these organizations, the PACEU would not exist. Here is the disclosure for participants prior to the activity. And the next slide here is our activity check-in. If you are wanting to receive CME or CNE credits, we ask that you please scan this QR code. Our activity code for today is 3984. Don't worry if you don't get it on here. We will put it in the chat throughout the presentation, and we'll also put the activity code so you can go ahead and log on and sign in for that. Okay. Our next Grand Rounds will be on February 20th. Miss Onique Hennigan will be speaking to us, and she is with the University of Texas MD Anderson Cancer Center. She is one of the community relations specialists. We offer multiple different types of trainings and presentations, different educational efforts for both community and health professional. Currently, we are having several trainings for pesticide use, as well as childhood cancer and its relationship to environmental exposures. So if you're interested in either of those two topics or any other topics related to environmental health, please go ahead and email us, and we'd be more than happy to set up a time with you or let you know what we already have scheduled. We will provide our email addresses in the chat so you can contact us if you're interested. So without further ado, I am pleased to be joined today by Dr. Jordan Vaughn. Dr. Vaughn currently serves as an assistant clinical professor of emergency medicine at Louisiana State University. She is the social EM director and the Louisiana State University Diversity, Equity, and Inclusion Associate Director. Dr. Vaughn also serves as the Public Health Clinical Director for the New Orleans Health Department, where she works on projects that involve health equity, community health, and improvement and strategy development for the Office of Violence Prevention. We're very fortunate to have her with us today. I have heard her present in the past, and it was wonderful. So we're so happy. Thank you so much, Dr. Vaughn, for being with us.
Yes, thank you. All righty, so let me share my screen. All right, and you guys can see this okay?
Yep, if you'll just click hide on that little pop-up, and then you should be good to go.
All right, perfect. Well, thank you guys so much for having me. As mentioned, I'm Jordan Vaughn, currently emergency medicine physician by training. I'm so happy to be here. This is obviously a topic that is near and dear to my heart. That The work that we've been doing in the violence prevention realm, but really making sure to place focus on the pediatric population is something that's so vital, especially now. So, thank you so much for having me. It's such an honor to be here, and I hope we can have some great discussion later. But just bear with me. This is obviously a very touchy subject. So I always leave space for those that may be triggered by any of the topics or things that we discuss to kind of give yourself peace, give yourself space. And then, hopefully in all this, we can learn something together, grow from it together, and, increase our collaboration. So thanks for having me, and just bear with me throughout this presentation. So today, we are hopefully going to talk, or we are going to talk about the current state of violence nationally as well as locally. I would like to talk about some of the historical shifts that have happened in violence, as well as with a focus in the pediatric population. We can't talk about violence in the pediatric space without talking about ACEs, so we will have some time to discuss that. But I really want to use the bulk or the chunk of today to really discuss different programs, systematic programs, community programming, things that we can do as clinical physicians or in the hospital setting to really work on primary prevention, secondary prevention, and that role that we have in that space for prevention mechanisms. So just to get into a little bit and putting my public health hat on at this time, and just discussing violence in America as a whole. Of course, we can't talk about violence without talking about homicide, with this being the cause of death for more than 26,000 Americans per year. A large percentage of this, at 76%, is due to firearms. We are seeing that different communities are inequitably distributed. So we see Black individuals that are 4.5 times more likely to be killed than their white counterparts. We see within different age distributions and demographics that this is the third leading cause of death among ages 1 through 44. But of course, while we're all here, I like to highlight in bold because this is a leading cause of death in children. This is something that historically has kind of shifted to the point where in the past, 5 to 10 years ago, we're seeing that motor vehicle accidents were the causes of death and injury in children. But now we're seeing that these are firearms, so in homicide. So really looking at this patient population with the specifics on pediatrics today and really highlighting that as the importance of the work and why we're here today. Of course, highlighting that this is also a leading cause of pregnancy related death. So, as we look at children in that specific population, keeping in mind that those individuals that are pregnant also have a lot of children in the home, so they are too disproportionately affected and highly impacted as well. When we look at violence in America, I love this graph, and the CDC has great infographics as far as like the historical context of violence in America. Because a lot of times when we think of violence, we think of firearms and we think of homicides. But one that's not really discussed, I feel like, as frequently is that firearm suicide rate. So I like to kind of highlight that as this kind of distribution. And we can see, of course, the different disproportionate groups affected when you look at homicides versus suicides from 2019 to 2020 in different racial ethnic groups. And then to the right here, you can see the trends. So from 2011 to 2015, you kind of have that lower trend, and then it spikes up in 2015 with your firearm homicide rates. And then that just further increases from 2019 to 2020. Of course, we all know what was happening likely around that time, whether that, there's still studies that are looking at the effect of that. But just looking at the increasing rate and how vast and rapid that rate has been in firearm homicide rate as opposed to firearm suicide rate calls the question, what are we doing? Why those underlying causes exist, why that rapid rate is existing within that time course and just continues to rise. When we look at violence in pediatrics as a whole, we have a large proportion of children that are affected. There are estimated 1 billion of children that are affected at any point in their life. Half of these children in the world are victims of violence every year. Again, when I mention violence, we're not just talking about firearm, we're not just talking about penetrating or gun injury. We are talking about psychosocial, we are talking about physical, we're talking about verbal, sexual abuse. All that is included in this number of a billion. a lot of times when we talk to stakeholders, a lot of people ask why. Why is this important? Why should I care? And a lot of times with stakeholders, everyone is responsive to money. Okay, dollar signs. That's what moves with the world. So the economic impact of violence against children and youth is very impactful at hundreds of billions of dollars per year, upwards of 122 billions of dollars a year in children. But we see, as mentioned before, if disparities do exist, there are certain groups that are going to be higher risk. So we're looking at girls, young women, those that are going to be more vulnerable to certain types of violence than others. As mentioned before, that number of 122 billion annually, this is the estimated cost of youth violence worldwide. We see in the emergency department, and taking it a little bit home for me personally, nationally at any point in time, there are 800 youth that are treated in the emergency department on any given day from any physical assault related injuries. Again, when we're looking at the different populations, we can't have these conversations without realizing that some are going to be disproportionately affected. So that's going to be a common theme and something that you're going to hear very frequently from me today. But with homicide, that's no different, and the leading cause of death for non-Hispanic and Black individuals and youth being more high risk. I love this quote just because it highlights that there are different experiences, especially in early childhood, that make it predictable. We know that certain individuals, based on our knowledge and research at this point, are going to be higher risk than others in the community. So, really making sure that as we're having this conversation, it's important to talk about interpersonal, youth violence, intimate partner violence, and really trying to get down to who is the high risk, making sure that our interventions are effective and specific to those high risk populations. So when we talk about physical and mental health, I think currently at this point within the realm of violence and the impact of gun violence, the focus has really been on the physical and mental health, which I think is great. But a lot of what we don't currently know is like the early development, specifically in youth and younger ages. So for every fatal shooting, we know that there are a sequela of 2 to 3 other non-fatal incidents that are likely in relation to that one fatal shooting or incident. This does require and is a huge burden to the medical system, but does require ongoing medical care, ongoing mental health services. And just for one individual to be taken care of in the emergency department, it is nearly $18,000 in a study that looked at this at Tulane here. So we're definitely seeing that cost burden, but not just taking in effect the cost burden at that one time and that one day and moment, but just taking on effect the disability, the functional limitations, the PTSD, the trauma, the mental health. All these are for sequela of that one instant in time and fatality or incident. Looking at the impact of violence on early childhood development, of course, we're seeing, as mentioned before, the demographics of this, right? So, lower income children, Black and Hispanic children, male children, we know are higher risk. A lot of times in a lot of intervention, they are the main primary goal and focus of a lot of primary prevention because we know that these communities are at higher risk. But we also know that there's some positive predictors to youth exposure to gun violence as well. So that's class, the environment which those live, their age, their gender, their race. Um, we're starting to look more at the most common routes of exposure. So, where was it that these incidents are happening more frequently? Are they happening in the community? Are they happening in schools? Are they happening, during school, after school? Really looking at when the highest impact of violence is happening in these communities and as age groups that we can be very intentional about prevention. Studies are starting to shift, and I think it's great. And I love this study before as referenced because it's starting to look at the cognitive development. We know from ACEs, we know from stress and cortisol, the impact that that has on your chronic physical health. So, whether that be diabetes, hypertension, we're starting to see over time the impact of that. This toxic stress known as violence in our communities does have an effect on learning and behavior, and we're starting to see that. And I think people are starting to take note of that and studying that in the age or young group, in the younger age group, and that really effect that violence has on their impaired cognitive development and mental health as well. As I promised, we cannot talk about violence without talking about the ACEs in pediatrics. So, within the age group of 0 to 17, ACEs are known as adverse childhood experiences. These have long term impacts on health and well being. As I mentioned before, a lot of what we're focusing on today is gun violence or homicide, but ACEs are really important to talk about because they do take in consideration the experienced violence, abuse, and neglect that children experience or what they witness. So I think a lot of time people forget in ACE that it's witness violence in the home or community. Having a family member that may have attempted or unfortunately passed away from suicide, or even having a family member or a parent that has been involved in a criminal space. So those that may have been incarcerated for any point in time also is considered an ACE, and something that we take in consideration in the pediatric population. When you look at ACEs in pediatrics, if I was to sit here and survey everyone here on a call and I could get you all in one room, about 2/3 of us in this room will be able to raise our hand and say that we've at least experienced one ACE at any one period of time in our life. This is huge. Of course, we know that while, a high percentage of people at 2/3 may have experienced just one, um, there are definitely more individuals in from those different risk groups. So, highest among females, non Hispanic American, Indian, or Alaska Native adults, those who are unemployed or have been more heavily impacted by the social drivers of health are going to be at greater risk of having even more than that one reported ACE, but upwards of two to three. ACEs are costly, just like violence. ACEs are within the same realm, with about $748 billion annually. And that's not just looking at the United States, but more so in Bermuda and Canada through recent studies that have came out. The good news is, not to be a Debbie Downer, that violence is preventable and we can all help young people grow without violence and reducing um, the factors that are mitigated into exposure of ACEs for children. When we look at this strategy, especially specifically here in New Orleans. I know these conversations are happening really everywhere in the nation, specifically about this holistic strategy, this public health approach, really recognizing violence as a public health crisis for what it is. We realize that we have to do this holistically. I think best practices that were in the past kind of looked at this as a more, this has to fit in one specific lane. You have to do it one specific way. And I think that over the past 5 years, especially in research, we know that best practices are limited, but they do exist. And more research is coming out in best practices, which is super helpful. But we're seeing that it isn't just funding or initiatives that should be focused on one pillar or one theme, or within one lane, but it has to be all of the above. We really have to take this from like a multi-pronged approach. Here in New Orleans, this is an approach that we've taken to our strategy as far as our violence prevention efforts. And I think that, decreasing silos, of course, increasing collaboration and strong collaboration among, the strengths of all your partners is really how you're going to get the job done here. With this holistic strategy for violence reduction is kind of, I think, within three prongs. So, of course, you want to stop violence and do that well. So, firearm deaths are preventable. There's some different ways that everyone can, play a role in prevention. Realizing that there's going to be challenges. Every community is going to be different. What works here for us in New Orleans is not going to work in Baltimore, is not going to work in Chicago. And I think realizing that, welcoming the challenges, and being open to those challenges to find methods for resolution. And then advancing equity. You have to have a comprehensive approach when you're working with different communities, incredible messengers in the community. And you can't do that without reducing inequities to prevent firearm deaths and violence. When we look at this holistic strategy, it's so important with different neighborhoods recognizing that there are certain neighborhoods that have income inequality and concentrated disadvantage that are going to experience higher levels of mistrust, social disorganization, and as well as violent crimes. We cannot address violence in America without addressing these things. Failure to adequately address these issues will only further perpetuate violence in our communities. So it's really important and in our approach that we are recognizing these across generations in our historical contexts to be successful in decreasing violence in our nation. This is going to take everyone. So I love this and it's very busy. I know, I apologize, but you have multiple upstream and then you have your downstream effects of different implementations of violence prevention in this space. Of course, you have those social drivers. So you have those living conditions, the environment, equitable access, economic opportunities, income. But then you have your institutional inequities, access to care, access to resources for individuals, and then your social inequities as well. So all of these are correlated. You can't just focus on one specific prong, as mentioned before. We can't just focus on disease and injury and ignore the rest and think that we're going to have impact or that we're going to be efficient in actually reducing gun violence or violence. This is our violence prevention strategy. I talk about pillars a lot, and this is what I'm referencing to. Our partners at Tulane Violence Prevention Institute have been very vital and instrumental in helping us with creating our evidence based strategic pillars. So, I do not have the time to go over all these in details. I will try to highlight all of them, if or some of them, if not all. But a big focus of what we're going to talk about today is going to be in our hospital and community-based intervention, our trauma-informed care, and we'll touch a little bit on youth development and opportunities and programming. So when we look at hospital and community-based interventions, I think a lot of what people traditionally think of in a community-based, maybe like cure violence, or ceasefire or prior reiterations in different national programs that exist. But at the core of every community-based program, you have a community violence interrupter, as well as having, community interventionists. We use the word or term community interventionist, such as a fancy word for case manager. They essentially following that individual for 6 months to a year, carrying that caseload, working with them, connecting them to the social drivers or health and resources that they need to thrive, and more so looking and taking a primary prevention approach. And then we have our community violence interrupters, our credible messengers, if you will, those in the community as well as those in the hospital based setting. Here in New Orleans, we separate them just because in prior reiterations of our programming, we've realized that one group didn't have the capacity to be in the hospital and in the community. So we do it in two different prongs, but other models, especially in California, I know they have one set model where, their interrupters are going in the community as well as in the hospital setting. With the focus on the clinical setting, you have the hospital-based violence interrupters. Their main focus, as well as the intervention, as is mentioned before, is just strengthening the economic and household stability. So figuring out what resources, doing this through housing assistance, any childcare subsidies, tax credits, livable wages, different things that the interventionist can do and follow that family through to make sure that they have the resources that they need to survive. Those interrupters are going bedside in the hospital. They are focusing on reducing retaliation. They're trained, they know the words, they're credible messengers, they're from the communities that they represent, and may have even had a life imbalance prior, and they're looking to go into that mentorship role of helping others not fall victim to the same lifestyle that they may have had. So these are credible messengers that are really caring or at the heart and core of the work of what we're doing in the hospital and community setting. We shift a little bit to our credible messengers and our interrupters and interventionists, and we kind of shift to what can we do as a clinical provider. I think often we go to med school, we go and we do our training, and we're taught the medical and that hidden curriculum, right? It's just hidden, it's in there. You have to kind of get it how you get it. You have to figure it out along the way. And I think that one thing that we're doing a lot better in medicine is being intentional about realizing how impactful the social drivers of health are into integrating that into the visit. Yes, there are a lot of studies that came out, and all of them note barriers of timing, right? You have 15, 20 minutes in a visit. How am I going to do all that I need to do in their medical visit? And then also talk to them about making sure that the parents have a gun that's safe and stored correctly. These are still barriers that I think that we all face, but I think that there's ways that we're learning and finding ways to implement into our care and our systems and processes to make this easier. This is a protocol that I'd like to highlight today, the American Academy of Pediatrics Primary Care Violence Prevention Protocol. I think it's great because in addition to the intimate partner violence screenings that we do so frequently and that are kind of like traditionally ingrained over years, they're starting to do gun storage screenings. So identifying if there's any parents or anyone in the home that has any gun available, how it's stored, is it stored safely, who has access to it, and really doing that screening. In addition to the screening, talking with children about firearm safety, dating violence, bullying, also, going that next step and doing any local or national conversations with policymakers. You know, having that realm in advocacy is so important. To care what we have to say, we're living it. We are the professionals in that instance. We can really impact policy. And so I think it's important that in this protocol, they're empowering pediatricians that are now being trained to kind of see themselves as being vital in that space and important. The main setting in the primary setting is just prevention. So, coordinating and integrating responses to violence in a way that recognizes these connections, recognizing ways to identify different ways that as providers we can kind of bridge that home environment, medical, and larger community with bridging individuals to the resources that they need to thrive in the community. Through this protocol, they kind of divide it into three pillars. So, community, education, and advocacy, as I mentioned before. That education is really just on um, creating different elective coursework rotations for medical school, postgraduate training, and residency, making sure that residents are aware, and not that you have to be a case manager on your own right, but just that you're aware about the community resources for referrals and different things that you can give to parents to help them thrive and be more successful at home and in the community, and then different continuing medical education opportunities. As far as in the community, again, that's just education, bullying awareness with teachers, the clinical system really working collaboratively with the community, with the health education system, and kind of bridging that gap. And then again, the gun safe storage practices as well. Be Smart is a campaign that I would like to highlight. This was launched in 2015 to promote responsible gun ownership in order to reduce child gun deaths. This is something that we've implemented here at the health department through a partnership with Children's. I know that this is probably one of the earlier first models. I think we're the second site. But this is definitely something that's taken off, something that federally they're looking to invest more in. But specifically with Be Smart, prior reiterations of gun safe storage has been surrounded with cable locks, but these are free biometric gun safes. So we've been able to partner, receive the funding to have children screen in the emergency department in their primary care settings, identify those that need biometric gun safes, and then they're able to come at a designated time to pick them up. But we've also been working with Ubuntu, our credible messengers in the community, in different opportunities in the community to essentially, try to get the gun safes to people who can't necessarily go all the way uptown to a hospital. Make sure that we're making sure that those resources are equitable and available for everyone at like community events and different neighborhood events that are local in the city. So that's been a great opportunity for us. We see that it works. So, out of the recent study that we had, that we're going on the second year now, but in the most recent study and follow up, 40% of the respondents reported that someone in their family had experienced gun violence at some point in their life. 72% of the households that were surveyed at the time with firearms did have children in the home, with 40% of those with children in the home reporting that they did store their guns fully loaded, and with 30% of them storing them in a safety box, which means that a large percentage of them were not storing them in any safety means at all, which means that, of course, our children were very high risk in these homes. So, with 75% of these homes having children in them, it was very vital and important that these communities were receiving this access to this storage device. After 12 weeks, 83% were using the box from the 30% initially in the beginning. And this same cohort was followed at 6 months that reported 94% always using the lockbox to store their firearms. But my favorite part here is 100% reporting that they felt their children are now safer in the home. And that's what we're all here for. I think one point that I didn't put here, but is also important, was that a large percentage of individuals felt comfortable talking and recommending and suggesting and kind of advocating to other people in their homes and their family that, hey, this is important. Hey, I'm doing this thing. I have a biometric safe. They're doing this event in another 2 weeks. If you can't get one, I'm going to get one. At a lot of our events, people are coming and they're like, hey, my son has a gun in home, he has children, I need to get this for him, and we make sure that that individual or that household is getting it. It is so important that credible messengers who believe in the work are kind of spreading the word, and that's really truly how we've been effective with this initiative. This is just to highlight another study, essentially that has looked at pediatricians, being empowered, looking at their confidence level in counseling towards these certain things. But essentially, this was looking at decreasing and counseling towards limited media usage, which we know, can perpetuate violence for youth, as well as storing firearms. This study specifically was looking at cable locks, so not necessarily biometric locks, but again, this is the mainstay of what a lot of different programs are currently providing. And they're seeing increases. So they're seeing that there's a substantial increase in storing firearms, a decrease in media usage after counseling, and that people essentially are, responsive to that pediatrician being active, and they're seeing that effect. So definitely, when we're looking at confidence of providers being comfortable in that space and doing the work and getting people involved, this is definitely something that is within our wheelhouse, and is in our lane, if you guys have heard before. When we look at another pillar, just want to take some time to highlight the economic and practical family supports. At the health department, we really rely on our different programming to essentially connect and focus on bridging that economic gap. So whether that's through anti-poverty programs like WIC, whether that's decreasing short-term financial insecurity with different bridge programs, increasing those with access to job placement, paid family leave, positive parenting and safe environment training, and then reducing food insecurity. There are different programs like SNAP and different grants that we've had. We've definitely tried to focus on bridging this gap, doing different studies and figuring out which zip codes are at higher risk and where to really focus a lot of our programming. One I'd like to highlight now is just our maternal and child health program, Family Starts, which is going into the homes at 6 weeks postpartum, for any individual that just recently delivered. So it's so important. These nurses are going in the home and not just checking on the medical, how are things going between you and baby, but also identifying if there's any referrals, assistance, or economic barriers that are preventing that family from thriving in such a vital and important time in development for a family. So that's something that I think has been very impactful and definitely something or a part of our pillar in our entire ecosystem that we're looking at as far as violence prevention. I know other programs are doing that nationally. Now, for my favorite part, the community-based intervention. So I already mentioned before the community violence interrupters and interventionists, but essentially this community outreach is vital to ensure that people with the greatest needs are connected to the services that they need to reduce those tensions. For we know poverty is violence, racism is violence, and so it's important that we are placing emphasis on these things to reduce, to be effective. For any community based interventions, or what a lot of other people describe as CVI or community violence intervention, it's an approach that we have used nationally to apply evidence informed strategies, to reduce violence through tailored community centered initiatives. So I highlight these two here. They're very popular: READY, Advanced Peace, Cure Violence, Ceasefire. These are all programs and prior reiterations of successful programming that has actually been shown to reduce violence. Our prior former Cure Violence, we went in Central City back 6 years ago, with like greater than 100 days of no shootings and no homicides in the target zone that Cure Violence was in at that time. So we see that this works. We see this not just locally, but nationally as well. It's important when you're looking at CVI that you have a focus on specific things that kind of make them successful. So two of these are guiding principles and evidence informed. So I talk a lot about the evidence-based methods for any CVI program to make sure that you have partners that are able to do the research and evaluation of the programming that you're implementing, but also taking into consideration the needs for the communities that you're serving. That kind of goes into our guiding principles. Doing any work in a community without realizing the community's needs and listening and doing intentionally what it is that they need from a needs assessment is done in vain. A CVI approach must be informed and must be tailored to the way that the culture of that city is going to receive it, and in a way that it is going to be successful for them to thrive and for it to be effective. This means that the social service partners that are engaged or aligned must collaborate with the residents, collaborate with, law enforcement, collaborating with private partners, different community members to really build this community and this ecosystem, which is something that I'm proud of that we've done here in New Orleans. The other two prongs of a successful CVI are also within equitable and inclusive work. So just making sure that the care that we're taking to guarantee that the individuals that are receiving the services are the most affected, the most disenfranchised, and are the ones that are the highest risk that you're serving, so that they can benefit from them. And then lastly, effective and sustainable. So you can go into any community and do something for 6 months and it can be great and it can reduce, by a large percentage. But that is pointless if after 6 months that program goes away and is not there anymore. It is really important that as you're thinking about our programming, and something that we're, very intentional about in our programming here, is that you're sustainable, that you have methods that have longevity and are going to demonstrate measurable impacts and well-being that can be implemented for a long, period of time chronically in the community that you're serving. Here, our community intervention interrupters that we call our peace ambassadors are through Ubuntu Village. They're amazing. They do everything from city hall, council, and meetings, and advocacy work, panels, community drives, show, different education events for the kids, events for the unhoused. They're really doing it all, and they're very vital in getting to like the daycare systems and the school systems to do the gun safe storage distributions and making sure that the communities are um, aware of what resources are available, doing that case management, following them over time in case loads to really work with the highest risk. So they're amazing. I'm biased, but I obviously love them and they're doing great work. Um, in addition to the community outreach and the presence that they have in the community and really being those credible messengers, a big focus is on risk reduction. So, focusing on, again, the connection to employment, mental health assistance, which we'll talk about a little bit later, help with different educational needs, that mentorship. That's what their main aims or goals are. But shooting responses, having the ability to respond to the scene of a shooting, to go and to talk with the family members and prevent and reduce retaliation, work on mediations in the primary standpoint to reduce retaliation or prevent events from even happening. I mean, they're really the professionals. And I've learned so much from them. I think they're literally amazing. But this public health approach essentially is something that we try to perform in every lens and context and apply to everything that we do. And so with Ubuntu, this is no different. This is through community collaboration, forming relationships with stakeholders that can help them to provide the community resources that they need to be successful. I mentioned this here. I don't have the time, but I just wanted to highlight the other programs. And kind of when we talk about this ecosystem, it's not just Ubuntu, it's not just the hospital, it's not just pediatricians that are doing this work. These are different initiatives that we have here in New Orleans and that are similar in other cities as far as mobile crisis units that are responding to 911 calls with mental health trained professionals so that they can lessen NOPD's response and they can solely respond to safe scenes, obviously, to essentially get those individuals in a safe means or method to the care that they need to receive. Lead sobering centers, Center for Restorative Approaches, which is doing the same thing that Ubuntu is doing, but mainly in the schools with conflict mediation circles. The AIR program, which is within the domestic response and pairing individuals that have suffered from domestic violence with advocates with the resources that they need from that time that they're in the hospital, are all included in that community-based aspect of violence prevention and in our ecosystem as well. Can't talk about pediatrics without talking about youth development. Looking at summer work, summer jobs, focusing on that economic pillar, so that many individuals and youth and teens, they may be a primary source of income and support for that family. And so, creating opportunities to where they can make and assist and help their family to be successful economically, creating summer jobs, but not just summer jobs in that 8 to 12 week period, but expansion to year round programming so that that economic support can be more chronic and long standing. Youth development. So we talk about the impact of youth development and brain development, as well as mental health. So really pairing them with mentoring, focusing on at risk or system involved youth, and doing this with the schools and in partnership. Our school associated programming, overall, a lot of them have been surrounding education, awareness, conflict mediation, like our CRA programming, and anti truancy school retention. And these have been a lot of what the focuses have been nationally. But here I just wanted to highlight a little bit of what we're doing locally. So, Office of Youth and Families with Summer Jobs and Pathways programs, GROW, Mellow, our Teen Court Diversion program, ERC, and then Thrive Kids, which I'll be talking about a little bit later. But essentially, just to wrap up the pillars that we've discussed so far at this point, everyone has a role to play. Whether you are in a clinical setting, whether you are in the community, whether you are, higher up in administrative or you're a policymaker, everyone has an opportunity for impact in this pediatric population through the means that we've discussed before, as far as strengthening, youth skills, connection to youth and caring, and different adult activities, safe and community environments. We all have a role to play. When we look at trauma informed care, just like we're trying to look at all initiatives and things that we do here in New Orleans with a trauma informed or with a public health approach, I would say that the same is with a trauma informed care and lens. I don't think that you can really do, or that we could do, anyone here could do what we do in a violence prevention realm or space without having a trauma informed lens or approach to any of those things. So, everyone at any point in our system does receive trauma informed care from our TRC or Trauma Recovery Center, Seeds of NOLA, receives training within that, so we can make sure that as we're bedside, whether that we're in the community, everyone is informed and everyone is able to provide their services with that trauma informed lens. When we talk about trauma informed care, I'd like to highlight the Trauma Recovery Center. There are multiple trauma recovery centers that exist nationally. Here at the TRC, also known as Seeds of NOLA, they are rooted in the principles. They've been around for a while, but we've just been able to expand their services to include free services to those in New Orleans Parish. Anyone, and this isn't not just penetrating injuries or community violence, but motor vehicle accidents, sexual assault, domestic violence, interpersonal violence, any work related injuries, anyone that falls within that realm of their inclusion criteria, which is vast, thankfully, um, they're able to provide and receive services for free. The services provided is vast, but support groups, individual one-on-one care, CBT, legal assistance. They have case management that's there that's able to kind of do that multi-pronged approach and make sure that people have the resources they need to heal from the recent incidents. And then, of course, we all work together in our ecosystem. So TRC and Ubuntu, TRC and the health department, we're all talking to each other on a regular basis and working with each other to create those community referrals to make sure that everyone gets the resources that are needed. Within the pediatric space, we have Thrive Kids, which is an amazing program. It provides various medical and behavioral services to staff, to children, serves over more than 180 schools across Jefferson and Orleans Parish. There are similar models to Thrive Kids in other places as well, but they have a vast number and it's growing of staff members and capacity to provide services. I mean, the stories that I hear from the kids that they work with literally will make you weep. But it's so impactful. It's so important that, just bringing that back to those ACEs that we know exist, that we're able to kind of provide that primary and secondary prevention early in life, rather than waiting until individuals are 18 or 20 or 24. And doing that earlier, definitely, we know is more effective. So Thrive Kid in our schools this past year has served and provided resources for more than 10,000 children. More supportedly, they've been very active in their response post COVID-19, because we all know that the response was needed, but to more than 3,000 schools and early learning centers with technical support in how to retransition and provide the services that are needed to children in that period, and to continue to do so. So definitely shout out to Thrive Kids. As far as violence in America, always looking, and I think, before look data, we need evidence base. This has definitely been something that we've needed a shift in paradigm and support funding and continued funding for advocacy and research in this space. As we recognize this as a public health threat, leading cause of injury and death, it's really important that we continue to form the science for solutions, these multi-sector collaborations, this physician leadership that is needed and has been shown to provide benefit to these communities. When we look at this ecosystem in violence prevention, we're looking at everyone involved. So, our local government, our business and civic leadership, community faith based groups, advocacy groups in the community, as well as our nonprofits and philanthropy groups. I like to end today with this quote that I love. We have to figure out how to break down these barriers and work in a more collaborative way, to not just within the health system, but across the social services system and the criminal justice system. It is so important today. I know I've highlighted and I've shoved a lot down your guys' throats this morning or afternoon, wherever you are, but it's so important that we recognize the need to decrease silos, the need to work collaboratively with all groups, recognizing that there is not just one way or approach to do things, and that we may have to revamp or rechange the wheel. So, figuring out how to break down these barriers and silos and be more collaborative and working together towards this common goal of protecting, our nation, our children, which is our future, is ultimately what we need in the health system and across all systems to essentially decrease and reduce violence nationwide. So I thank you for your time. Again, thank you so much for having me. I know I just get a lot, and I know we'll leave some space for questions. So I'm happy to be here for any of the questions that you guys may have. Thanks so much.
That was wonderful. And there's many comments here already about what a great presentation it was and how they enjoyed it. Interested, was housing part of the study, of this study?
Yeah, so we talked a little bit about mainly within the context of our social drivers to health with the housing. So as far as primary youth housing, I didn't mention them, but Covenant House, or one of our partners that we work with, one of our stakeholders in the community that we work with our youth and housing opportunities. More specifically within women or youth shelters. We also have different partners that we collaborate with. We have standing meetings and collective meetings. So, depending on our needs and connecting our community and hospital based interventionists to partners and stakeholders in the city, a large focus of that has been housing. So, fortunately, we've been able to provide flex funding to kind of help and aid individuals in either not losing housing with like emergency funds or getting them connected into housing and rapidly rehoused. So definitely it's not something solely as an agency, as the OVP that we do, but something that we work with different city offices and partners. But housing is definitely a large part of what we do.
Thank you. Any other questions? Okay, well, one more time, thank you so much to Dr. Vaughn for being with us. And we look forward to seeing you again next month. We'll have another presentation for you from Miss Onique Hennigan. And all right. Well, thank you all. Have a wonderful day, a wonderful long weekend, and we'll see you soon.
All right, take care. Thank you.